I'm really honored to be able to speak to you all about this topic today and to tell you about a new initiative at Stanford that was launched just around 2 months ago with a tremendous amount of support from the hospital and from the community. And we're very grateful for this opportunity, and I want to tell you about it today. And I also want to mention I'm incredibly humbled because I learned that the last time this talk was given, it was given by Jerry Reven, who is one of the founding fathers of the metabolic syndrome and insulin resistance field, which is so much a part of this problem that I'll talk about today. So I'll do my best, but I know I can't measure up to Jerry, but it'll be my honor to try. So today I'm going to talk to you about the Stanford South Asian Translational Heart Initiative. This is a program that will start here at Stanford, but our full intent is to stretch our reach to South Asia and to form partnerships in a global level because this is a global problem. It has unique features geographically, depending on where you look. There are slight differences, but the overall trend is alarming, and I'm going to talk to you today about some of those trends. Briefly, today we're going to speak about some of the statistics about coronary disease risk in South Asians and how the traditional risk factors that we use for the general population apply and also don't apply to this population. I'm going to talk to you also about SATHI and how its comprehensive cardiac risk assessment we feel may hopefully improve upon our traditional risk factor assessment in this population. And then speak about our clinic and research goals, and finally, what we think you can do to protect yourself and your family from what is becoming an epidemic. So I want to start with a case today of a patient I had who is a 44-year-old male engineer here in the Bay Area who came to me with no prior history of heart disease. He was young, he was very active, and he said that occasionally he got short of breath but did not feel like it was exertional. He could run, although it wasn't clear exactly how much he was able to run. He was able to exercise fully, in quotations, 3 times a week, about 40 minutes or so, and said that he didn't have any specific limitations or recent worsening of that. And he said it was usually light running and occasionally cricket. And one can argue about how much cardiovascular activity there is when you're playing cricket. It depends on what you're actually doing, but upon further questioning, it was a mix of running and standing. So he was an occasional smoker, a social smoker on the weekends with friends. He would have a couple glasses of whiskey, perhaps, and a couple cigarettes, but no more than that. His blood pressure was borderline, 130/85. He had some diabetes laboratory tests that he came to me with, a fasting sugar level or a fasting glucose level of 104, which is just marginally elevated, and a hemoglobin A1C, which is a measurement of his last 3 months average glucose level. That index was upper limit of normal, 5.5, but certainly not alarming. He also had a cholesterol profile and was actually pretty close to normal in terms of the major cholesterol and lipid indices that we check. So he had actually come to me as almost a third opinion. He had seen 2 prior cardiologists. One had performed a stress test, and it was somewhat equivocal. It hadn't shown a real problem, and he wasn't sure what to do about that. A second cardiologist had said he needed an angiogram, and he had said no. He said, "I'm not interested. It's too aggressive an approach." He felt like his symptoms didn't warrant that kind of an approach. And so he didn't want to do an angiogram, but he did come to see me in Sati Clinic, and this was quite recently. And I spoke to him about his risk factors. And I took a tool that we all use in our clinic that is publicly available as well, where you can enter someone's age and some details about their ethnic background and some of their blood pressure and cholesterol values. And you can see I've entered those for him here. He's a 44-year-old male. He has these HDL, which is the good cholesterol value. A total cholesterol is shown here, systolic blood pressure. He was not diabetic. He did smoke. He did not have high blood pressure. And interestingly enough, the only categorization for ethnicity is white, African American, or other. And if you look, there's a little disclaimer in the bottom right-hand corner that says that this estimate may underestimate the 10-year and lifetime risk of a cardiac event or cardiovascular event in some race or ethnic groups, and South Asians are actually included here in this disclaimer. And his risk was actually fairly low. Over the next 10 years, it said his risk was 4.9%. The lifetime risk is a fairly generic lifetime calculated risk. It doesn't really vary too much based off your 10-year risk, but it was also in that intermediate range. And again, note the disclaimer. And when you went to the summary page of recommendations, it said that he actually was of a white or other race, and he would not benefit from a statin due to his 10-year cardiovascular risk score of being less than 5%. And so that was, probably the type of approach he may have received from any general physician that was taking care of him. If you plugged in his numbers, this is what it would tell you to do. So the last piece of information that really wasn't accounted for in that calculator I showed you was family history. And so I'm going to draw a family tree for you here. And if you've never seen one before, this pedigree is basically showing him, he's our index patient with a square around it, and his wife here. And piece by piece, his older brother, who was 46 years old, had actually just had a heart attack and had a stent placed at the age of 46. So a first-degree relative who has had an early cardiac event under the age of 55 for men, under the age of 65 for women. So that brother had had a recent heart attack and stent, and when I then expanded upwards to his mother and his father, his mother had actually had 4 stents, and she was now 70 years old. And even more alarming than her brother and mother having stents were that 3 of his maternal uncles had died from heart attacks under the age of 60. So this is a very severe case of early coronary disease and early coronary events in his family. And I can look out at the crowd and wonder how many of you have had a similar story in your own families where you've had someone in your family have an early cardiac event. And think about his situation where on paper and on the traditional calculators, he was not thought to be in the high-risk category. But looking at this family tree, I think you would all agree that he's tremendously high risk. So what he did agree to do, instead of the angiogram, was a coronary CT scan. And a coronary CT scan is like a specialized X-ray of sorts, and it does visualize the lumen of the coronary vessels. And what was seen on this vessel coronary angiogram from the CT scan was that all of his vessels were wide open except the left anterior descending coronary artery, which actually had a 99% blockage in the proximal to mid portion and had some bits of calcium, which is the bright area here, but you can see this vessel looking fairly good until this mid portion, which had a severe blockage. And that's represented here as well. So this was of tremendous concern to him. He actually underwent an unremarkable procedure to stent and open up that blood vessel. He's doing well now. He's on aggressive medical management. But the first thing that he said after I showed him those pictures and I talked to him about his family history and why he needed the angiogram was, why did this happen to me? How can I prevent it from happening again? And how can I protect my children from having the same problem? And these are things that are being raised on a daily basis in our clinic and many others, I'm sure, in terms of how to deal with this problem. So going through some of the statistics, I want to share with you some of the work that's been done and reported by our colleagues here in the Bay Area and others around the world that have looked at the incidence of coronary disease in South Asians. And in California, in fact, South Asians have 4 times the number of heart and vascular events as any other ethnic group. They have extremely high rates of insulin resistance and diabetes, dyslipidemia, metabolic syndrome, and vascular inflammation. And they have heart attacks that not only are happening more frequently, but they happen at a much earlier age. More than half of the heart attacks that are occurring in this population are occurring under the age of 50. And not only that, there is some evidence to suggest that after that first heart attack, that there is approximately a 40% higher mortality in some groups after that heart attack compared to other ethnic groups that are age-matched for that event. In India, the problem is not as well studied in terms of some of the demographics of the problem, but there's a lot of data suggesting that the problem is as big, if not bigger. In the early 2000s, coronary and cardiovascular events took over as the #1 cause of death from infectious diseases. And about a third of all deaths in urban India are from cardiovascular events, and as we all know, a large percentage of the rural deaths in India are probably undocumented or not sufficiently documented. So it's not really known exactly how prevalent it is overall, but it's certainly concerning. And actually, we have one of my colleagues in the audience here who published this study in 2004 showing that the rate of events in South Asians is approximately 4-fold higher than other ethnic groups here in California. So in India, cardiovascular diseases have killed on the order of 17 million people just a few years ago, 3 in every 10 documented deaths, and the prevalence of disease suggests that it's much higher in South Asians than in Europeans or in Chinese or in other ethnic groups. And it was felt that in 2010, India would be the home to approximately 60% of the world's coronary disease burden. It's unclear if that was confirmed with follow-up studies, but the trend has been alarming in that sense. The Interheart Study was performed by a group in Canada and looked at 1,700 South Asian patients who had suffered a heart attack and compared them to non-South Asians who had had a heart attack and South Asians who had had no heart attacks. MI stands for myocardial infarction here. And they looked at the risk factors that might be contributing to these events and felt that it was a combination of the diet, diabetes, and dyslipidemia in the population. On average, it's felt that South Asians develop coronary disease about 10 years earlier than other ethnic groups, and they tend to have more severe coronary disease at presentation. And this specifically means that when they do present, they tend to have blockages in upstream locations in the coronary vascular tree, meaning that those blockages affect a larger territory of the muscle on average than one that would be located further down the coronary tree. So that high risk, as well as multi-vessel disease at first presentation, raises the degree of risk for that individual patient. And in the California census, the most recent data suggests that the only demographic that wasn't living longer was the South Asian female demographic. So this is a problem that's not just affecting men who are South Asian, but also women at alarmingly high rates. This was the British Medical Journal study that showed that after a heart attack in the UK, the 6-month mortality was 2-fold higher in South Asians, and that the presence of diabetes accounted for a majority of that increased risk, really shedding a light on the presence of diabetes and insulin resistance as a risk factor, which I'll speak to in more detail. So, just to summarize some of the statistics, is that heart disease is now the #1 killer in both the US and India for South Asians. And South Asians between the ages of 20 to 55 can be considered intermediate to high risk based off of that alone, and that aggressive early onset of coronary disease is present in this population with a higher mortality after the first heart attack, and that this disease appears to be occurring progressively earlier as we start to see more and more patients coming in their 40s, 30s, and now 20s with significant coronary disease. Now the question is this because of improved disease reporting, or is this something that's been going on for a while? And I think that answer is still unknown, but there's no doubt that that is a trend that has been recognized. There's also the factors of lifestyle and diet, and those in the context of an economic revolution within South Asia and what interplay those have upon patients' lifestyles and diets has been the focus of several studies. So what about traditional risk factors in South Asians? Do they apply to this population? So let's start with smoking. This patient of mine was an occasional smoker, and actually tobacco use suggests that there is a slightly smaller percentage of use of tobacco in South Asians compared to non-South Asians. However, for those patients that do undergo angioplasty for heart attacks, they're more likely to be smokers. So clearly tobacco does correlate with the incidence of heart attacks in the South Asian population. Diet and exercise also play a role in higher risk of heart disease in South Asians. South Asians living in the US are found to eat probably too little fruit and too little meat or fish or protein and too high fat, and that the diet contains instead too much refined grains, sugar, and fatty foods. And then insulin resistance. Insulin resistance is a point along the continuum from a normal glycemic control or glucose control to diabetes, and it's thought to be a precursor to diabetes, and shown down below is a chart that kind of demonstrates the progression from normal to abnormal. And the diminished tissue response to circulating insulin is one way to describe insulin resistance. Insulin, as you may know, helps cells take sugar into them, and without sensitivity to insulin, that sugar level will rise in the bloodstream and not get into cells, and then you have some of the damaging effects of the high sugar as well as the high levels of insulin in the body. So that precursor to diabetes or pre-diabetes is something that carries with it risk, but which is not technically within the range of the diabetic categorization. And that normal lab values for diabetes, a hemoglobin A1C, which I mentioned below, of less than 6, and a borderline fasting glucose are often very consistent with insulin-resistant profiles, but are not a diagnosis of insulin resistance in and of themselves. One way to diagnose insulin resistance is using something called an oral glucose tolerance test. There are also several other types of tests to diagnose insulin resistance. These are testing protocols that are actually fairly involved, that are of varying accuracy, but are not routinely done for patients in clinics. That progression to diabetes from insulin resistance may take several years on average to occur. However, during that time, a patient takes on an increased risk of developing atherosclerosis and endothelial damage, and insulin-resistant patients may carry a similar rate of cardiovascular events as diabetics, meaning they may be in a high-risk category even though they're not recognized as being diabetic. So the diagnosis of insulin resistance seems to take on greater importance in this sense, and that doing an oral glucose tolerance test, and in our case, adding an insulin measurement at the same time. And again, this test is requiring an 8-hour fast, kind of like you're getting your cholesterol checked, and combines checking your glucose as well as checking your insulin at various time points. But that type of a measurement is a very good and accurate way to measure not only whether someone is insulin resistant, but whether it's a mild, moderate, or severe form of insulin resistance. But this test is really not routinely done because it requires the fasting and it requires multiple blood checks. It is a little bit more work for the patient, a little bit more work for the physician and provider, and yet it's a very important test, we think, to be done, especially in this population, and I'll speak as to why, because of the incidence of insulin resistance in South Asians. So what is the prevalence overall of insulin resistance? Well, because most patients are never tested, we don't actually know. But in terms of diabetes, about 23% of South Asian men and about 14% of South Asian women are felt to be diabetic. And we know that about 80 million Americans over the age of 20 are pre-diabetic. That doesn't split into South Asian or not, but one can somewhat surmise that this number of 23 and 14% may be much higher than we suspected. The interesting thing is that insulin resistance and prediabetes can not only be diagnosed, but they can be treated, they can be controlled, and preventing a patient from progressing from insulin resistance to a diabetic state is something that can be achieved, but you have to make the diagnosis first before you can actually make that intervention. Lifestyle changes, dietary changes, and if necessary, treatment with metformin, glyburide, pioglitazone, these types of medications can help not only reduce the risk of progression to diabetes, but even improve the sensitivity to insulin, which is the primary problem. Okay, so we talked about insulin resistance, we've talked about smoking. What about obesity? So obesity is a problem in the South Asian community, and it's traditionally measured using body mass index with a cutoff value of 25 kilograms per meter squared, taking into account a patient's body surface area. However, it's a very poor predictor of cardiovascular events in Asians in general. And it's been proposed by the World Health Organization that a lower target BMI may apply to South Asians, in this case, 23 kilograms per meter squared. And that doesn't sound like a lot of a difference, but it's actually a substantial difference. When I looked at myself, I was looking at this and saying, wow, I'm actually overweight for a South Asian. And I never thought of myself as such, but now I do. And as I learn more and more from my colleagues as well as from my patients, I realize that there are changes that I need to make in my lifestyle that are similar to what my patients and I am asking them to make. South Asians suffer from something called the thin fat syndrome. You may have heard this phrase before, where a patient's body type may not appear to be overweight or obese, but in fact, they have a different type of fat called visceral fat, fat that's within the abdomen that you don't necessarily see on the surface, but which coats the organs in the abdomen and elsewhere. And the presence and amount of visceral fat correlates pretty strongly with the incidence of cardiovascular events in patients. And this is something that has been shown not just in South Asians, but in other ethnic groups as well, and it's something that is used clinically, but is, again, not traditionally checked in patients. And then lastly, waist circumference and waist-to-hip ratio are more predictive in South Asians than body mass index is. Part of that is because of the cutoffs we're using, because at any given BMI, a South Asian is likely to have more body fat than a non-South Asian, percentage-wise. Something like a waist-to-hip ratio or a waist circumference can help to categorize a patient's body habitus as well as their risk of having metabolic syndrome. And metabolic syndrome is a constellation of findings that is actually rampant in the South Asian population. And I'll talk to you about that a little bit more. So this was published by a colleague of mine, Mintu Thurakia, about 4 years ago, looking at patients that they had measured waist circumference as well as various lab values from our colleagues at the South Asian Heart Center. And in this particular publication, they found that waist circumference plus any two of the following factors would better categorize a patient's metabolic syndrome than other classifications for metabolic syndrome. And in this case, a fasting glucose over 100, triglycerides over 150, a borderline blood pressure, or a low HDL or good cholesterol. Any two of these combined with an elevated or increased waist circumference would qualify as metabolic syndrome. And my patient that I showed you, he had an increased waist circumference. He also had an elevated fasting glucose, and his blood pressure actually was right on the border of this chart. So he clearly met criteria from those alone. And when you looked at the incidence of these criteria in men and women, interestingly, having a high waist circumference was quite prevalent in the South Asian population, and even one of the other risk factors also. When you met the criteria for metabolic syndrome, the number of women who qualified dropped quite a bit, whereas the men held steady at 30% or so. And it's felt overall that the metabolic syndrome prevalence is quite high in the men, but much lower in the women. It's not clear why that would be, but it is an observation that was made. Nevertheless, we use these indices to classify patients as having metabolic syndrome or not. Cholesterol in South Asians is also a risk factor that is true and correlating with events, even using traditional lipid measurements. South Asians are more likely to have elevated triglyceride levels and more likely to have a low HDL level or good cholesterol. In addition to that, and I'll talk a little bit more about this later, South Asians are frequently exhibiting low levels of HDL2B. HDL2B is felt to be responsible for much of the beneficial effect of HDL. And that subfraction of the HDL is low in about 84% of South Asians. So despite having a normal total HDL, you could still be at risk by having a low HDL2B. And again, HDL2B is not something that is traditionally checked in your clinic patients, but it is something that we are looking at closely in our patients in the Sati Clinic. Metabolic syndrome, as I mentioned, a huge epidemic among South Asians, much higher in men, it appears, than in women that have been studied, but I won't go too much into that. And here's a graph of the HDL showing the graph of a number of patients that were looked at, male and female, and where their total HDL levels were, and you can see how many of them fell under the low level of HDL and how young these patients were, under the age of 40, having low HDL as a major risk factor. So I mentioned before body mass index, total cholesterol, they might actually be lower than you would expect for South Asians, but despite having those things, the composition of their cholesterol profile appears to be abnormal. They have elevated levels of other risk factor proteins, such as lipoprotein a, increased inflammatory factors such as CRP, homocysteine, fibrinogen, and plasminogen activating inhibitor. And they have an increased incidence of insulin resistance, increased rates, and I didn't show this data, of psychosocial stress and depression. And these are all studies that have been published and available to us for many years, but despite this knowledge, it's not a routine part of our evaluation for our patients to look at some of these factors and to act upon them. And how do we act upon them, which would be outside of the norm of our traditional guidelines for non-South Asian patients? And that's something that is an outstanding question that we've tried to tackle through our clinic and our approach. So just to summarize the traditional risk factors, there are high rates of traditional risk factors in South Asians, and they do correlate with cardiovascular events. However, if you look at the actual scoring of traditional risk, it underestimates the coronary disease risk in South Asians. Whether it's the Framingham score, the Q-risk score, the Reynolds score, there are many, many others. These are consistently underestimating the risk that we know exists in this ethnic group. And it's believed that this is a combination of genetic, cultural, dietary, social stress, and even migration factors amongst the population. Insulin resistance is a hidden yet potent risk factor in South Asians. And as a result, because of the failure of traditional risk scoring to really capture the risk in this population, non-traditional screening may add value to that risk assessment. So I want to talk to you now about the Sati Clinic and how we're approaching our patients in this regard, as well as some of our research mission, and then speak a little bit about our comprehensive risk assessment and what that involves for patients. So Sati, as it's pronounced, means companion or friend in many South Asian dialects, and our clinical mission is to detect and treat heart disease and risk for heart disease in South Asians at an early time point. And because this disease starts on average 10 years earlier than other ethnic groups, our target population is a younger population. Now, I put an asterisk there because we are seeing patients both younger and older than that age range, but we are very interested in this age range as well because the disease hasn't often manifested itself yet as an obstructive coronary disease lesion or as a heart attack And we feel like there is an opportunity to detect risk factors and treat those risk factors and prevent progression to overt heart disease in this community. And this population is the one that is the least represented on the treatment side of our patient population. The second mission is a research mission in that these patients, if willing, can participate in innovative research into the genetic and physiologic underpinnings of their high risk. So not just a descriptive projects of who has insulin resistance and who has higher risk, but looking at actual translational work that can study from a genetic, from a stem cell level, and from an imaging biomarker level, the things that would predict as well as underlie the increased risk that a patient may have. So non-traditional risk factors, what are those? And why are they so important? Well, I'm just going to list a few of the ones that we and other groups are checking routinely in our South Asian patients. I mentioned already lipoprotein a, which is an independent risk factor for cardiovascular events, is elevated in approximately 40% of young South Asian men and 50% of young South Asian women. I recently had a patient who came to me at the age of 39 who had a lipoprotein a that was double the upper limits of normal and happened to bring his 12-year-old son with him. And his 12-year-old son had a higher LP(a) than he did. I don't know when he got screened, but it was within the last year and where. But it shows that this particular risk factor may have genetic underpinnings as opposed to an environmental one. But there's a lot of active research going at Stanford with some of my colleagues, and we're working together with those colleagues of mine to look at this population more closely. HDL2B, I've already mentioned. On average, about 84% of South Asians have a low HDL2B level, and this is also a risk factor that we feel is perhaps unrecognized, and even a normal HDL level can be associated or can be concurrent with a low HDL2B level. So this is something that we feel is very important to check. We do check more traditional inflammatory markers, CRP, homocysteine, and other cardiovascular risk markers such as ApoB100 and plasminogen activator inhibitor. Those risk factors are known to be abnormal in some South Asian studies that have been done, but are perhaps less linked with cardiovascular events than the above two. I've mentioned insulin resistance, which we think is incredibly important to check for in our patients. And then recently there was a study that identified 5 genetic loci associated with increased coronary risk in South Asians. And that is also, in certain patients and families, something that we are checking actively to look at a correlation between their risk and these genetic mutations. So we are screening all of our patients for the above 4, and in certain groups, performing a genetic screen for specific genetic mutations, depending on their family histories. The clinical mission in SATHI is to reduce the cardiovascular risk in South Asians. And what we are really striving to achieve at Stanford is an expedited appointment process so that we don't delay patients being seen and having their risk assessed. We find, particularly in the younger generation, that our responsiveness to our patients' schedules and getting them in, having them be seen quickly and having them be screened and educated a little bit more about their own personal risk is a motivating factor for our patients. And we've experienced a really positive response to that approach. We are much more aggressive in our screening. We are screening teenagers, 20-year-olds and 30-year-olds for not just traditional lipid scores, but for insulin resistance and for the more non-traditional lipid and inflammatory biomarkers I mentioned previously. We're treating aggressively. So in our clinic, we are often posed the question of whether to start a cholesterol-lowering agent or an insulin-sensitizing agent in a patient who may have insulin resistance or may have elevated cholesterol, but yet who is in their mid to high 20s. I saw 3 of them this morning. And the question is, are they of a high enough risk that it warrants starting a medication that is potentially a lifelong medication, and we are learning has not all beneficial effects, may actually have some harmful effects. And the question is, do the benefits of that therapy outweigh the risk? And these are things that we struggle with, but we understand that this disease in many of these patients is so aggressive that if you don't become aggressive with your screening and treatment, we can't prevent it from happening at such an early age. And so these are things that we are offering to our patients. And then lastly, we're offering long-term heart and vascular care. In order to make an impact on a patient's life, we can screen them for their risk. That's just a snapshot in time. If we don't treat and manage that risk and monitor that risk long-term, we can't reasonably expect that we're going to prevent an event for that patient. So that's something that we are dedicated to doing in our clinic. And then long-term risk reduction, which is hand in hand with the heart and vascular care. So who are these people? I don't want to go any further without mentioning some of the major contributors to our clinic effort. Abha Khandawal, who's also one of our women's heart health physicians, is working as a preventive cardiologist in the Sati Clinic. Monica Divakaruni, who is also seeing patients on the preventive side and is also an interventional cardiologist, is seeing patients in our clinic. Deep Banerjee, who is a heart failure specialist, and Anitra Romph, who is both an adult congenital and a pediatric cardiologist, is seeing some of our younger patients. And Timasimis, who is based at the VA, but has an ongoing NIH-funded trial to study insulin resistance in South Asians, is also about to start seeing patients. We have another preventive cardiologist joining us in about a month, who is coming from Boston to see our patients in Sati Clinic 1 day a week as well. So we're very lucky to have a tremendous team of clinical experts around me. And in addition, on the surgical side, I don't want to forget to mention Ahmad Sheikh, who's our surgical director, who specializes in transplantation and cardiac surgery, and Vinita Chandra, who's a vascular surgeon, who has a lot of interest in this population. So how does our comprehensive risk assessment program work? And a somewhat simplistic chart that I've drawn here is showing someone's heart disease risk on day 1 or week 1 of seeing us in clinic, and what we hope to achieve over a 6-month period. This 6-month period is something that we think is important to have 3 separate visits. At each visit, we do perform a distinct set of testing and counseling for these patients. Initially, we will assess our patients for their clinical risk, any evidence of active coronary disease, chest pain, shortness of breath with exertion. We assess their family history, as I did with that other patient, and we perform any sort of diagnostic risk stratification, whether that may be a stress test, whether it might be further laboratory testing, whether it might be an angiogram. And sometimes we find that we've uncovered hidden disease, and sometimes we find that that patient has no active disease. But either way, that patient has short-term goals in terms of their cholesterol, inflammatory markers, pre-diabetic state or not, and dietary support. We'll bring those patients back in about 2 months, review their clinical results, and we are developing our own risk score internally to share with those patients what we think their own risk is. And this is a combination of the laboratory investigations that we're doing, the risk stratification that we do that's clinical, and some of the research stratification that we do that I'll speak about in a moment. We perform a fairly intensive dietary consultation with our dietitian, Prajakta Renate, and we engage patients in something called the Cardinal Commitment. The Cardinal Commitment is a university or medical center-wide commitment where we promise with the patient, and the patient promises to us, that we will do everything in our power to prevent an event, and that they will do everything in their power to work with us to reduce their risk. And that commitment involves not just coming to their clinic appointments, but engaging with our biometric and mobile and cloud computing device integration into their clinical care. And then at that second visit, we finish with a research study enrollment. And what we're doing now is at this visit, we are actually performing a glucose tolerance test with insulin measurements to look at insulin resistance. And so at the end of your second visit in our clinic, we'll be able to tell you if you are insulin resistant and whether that's a mild, moderate, or severe degree of insulin resistance. We think that this is, as many people do, a very important, if not the most important risk factor for coronary disease in this population, and we feel like it needs to be identified early and treated early and managed such that it never progresses to diabetes and that it, in fact, hopefully regresses back to a normal state. The research study enrollment is critical at that time point because once we know a patient is insulin resistant or not, they'll be stratified into their groups for our research protocols. And I'll speak to you more a little bit about that. And then at 6 months, we'll actually review their research results with them and also see how their dietary follow-up looks in terms of how compliant they were able to be with some of our dietary recommendations. We'll be repeating our biomarker screening, whether that's blood testing and in some of the research protocols, imaging-based biomarkers, and we'll revise our SATHI risk score for them and develop a long-term care plan for them. And there are going to be patients, and there have been some patients who you can tell, we haven't been around for 6 months, but you can tell at the end of 6 months they may not have a lot in terms of risk that still remains. But what is important is that they maintain that low risk level, whether it's a high risk patient to begin with or a low risk patient. We want to make sure that their heart disease risk remains low for the duration of their life with the long-term care plan that we provide them. I also want to mention that at our second visit, before they engage in some of the research studies, one of the research programs that we'll be offering them is a biometric evaluation, looking at their exercise, diet, and sleep quality, integrating some of these components with devices. Many of you have probably heard of all of the apps and all of the new devices that will take some biometric information like heart rate, temperature, sleep patterns. What we don't understand is how we can gather a lot of data, but we don't really have a good understanding of what that means clinically and whether it translates into outcomes. And those are things that we'll be studying with our patients in this population. We've formed some partnerships with local biotech companies, and we'll be bringing some of those devices to our patients in the near future. So Stanford Medicine is global in the sense that we have reached out already to India in many ways, and we plan to do the same with the Sati Clinic. Stanford India Biodesign is a widely successful program that was started several years ago from recent graduates of the biodesign program here that is training new medical technology innovators with great success, and Sati is forming connections with some of those innovators in India to see how we can bring eventually some of our discoveries here to South Asia. We have also a history of working with health systems in India. This is just one example of HeartMap, which is looking at providing low-cost technologies in sort of an anticoagulation realm, but we can imagine forming partnerships on the cardiovascular realm more broadly. And then, of course, we've had a lot of technology interfaces and working on a big data project in India that is being spearheaded by Ewan Ashley, who is also one of my colleagues in cardiovascular medicine. So who's on our research team so far? And this is a growing list. I'm really lucky to be at Stanford. We can leverage some of the leading expertise in the world and some of these technologies to apply to this population. I do want to acknowledge Joshua Knowles, who's been incredibly helpful to me in terms of forming some of our research approaches to the insulin resistance problem. And he studies a lot of the genetic risk association in this population. Mike McConnell and Philip Yang are looking at a lot of imaging-based tools that can look at prediction of risk and inflammation in the vascular system and in the heart. I mentioned thymosinase already. Nigam Shah is one of our brightest stars in the bioinformatics field and has been instrumental in forming some of our database analyses, and we're hopeful to use his expertise in setting up our biodata and biobanking projects in India. I've mentioned Ahmad Sheikh. Joseph Wu is one of the world leaders in induced pluripotent stem cell technology, and one of our projects is to, in fact, harvest stem cells from the skin, from an oral swab from our patients, and patients who have a particularly high family risk as well as personal risk of heart disease. Those families and their iPSC stem cells can be converted into heart muscle cells in a culture dish. And we can study the behavior of those cells in response to various drugs and determine if that particular patient or that particular patient's family will benefit more from drug A or drug B, and why. And some of those technologies are incredibly powerful in terms of providing not only a personalized medical experience, but in advancing the field more broadly beyond just South Asians. Alan Young is our division chief on the clinical side, and Tom Katermos, our division chief on the research side. Both of them have been incredibly supportive, and Nan Huang as well, working on the stem cell projects. She's also an expert in vascular reactivity, which is one of our ongoing research studies. So specifically on the research end, what are we looking at? I mentioned Josh Knowles and his help with our genetic risk stratification in some of our patients. Cardiac fibrosis is a particular interest of mine. On the MRI side, cardiac MRI can actually measure the level of fibrosis within the muscle of the heart. I'll show you quickly in the next slide what that means. Vascular reactivity, I mentioned Nan Huang looking at the distensibility of your blood vessels, which is known to be a marker of cardiovascular risk, will be performed in many of our patients. Drug sensitivity, as I mentioned, in the stem cell technology, and then of course insulin resistance work that we're doing between Jerry Reven, myself, and thymosinase. Integrating some of these research projects with our clinical approach, our clinical treatment and preventive measures, as well as our dietary, psychosocial, and exercise support is how our clinic is structured, and then that 3-visit model that I mentioned. So I just want to speak quickly about some of the imaging components that we'll be using in this clinic. Cardiac MRI is actually hopeful to be a new one-stop shop in terms of risk stratifying patients. It can, in fact, is now the gold standard for looking at the function and size and shape of the heart and any evidence of prior heart damage. It can also have a cardiac MRI stress test that shows the brightness here in the one wall of the left ventricle is not as bright as the rest of the heart, and that indicates a perfusion defect or a lack of blood flow. And this is something that we can look at with stress or with rest and perform a stress test to say that this patient has a blockage. That's something that we do routinely in our clinical scanner and in our research scanner in the Falk building. We can also look at diffuse fibrosis, and I mentioned that before. Patients who have diabetes, and we believe patients who have insulin resistance, we can detect low levels of fibrosis within the muscle of the heart that we think might put that patient at a higher risk if they were to have a heart attack. And as I mentioned, some of the data suggests that the mortality is higher in patients after a heart attack, and we're studying whether fibrosis within the myocardium is actually one of the reasons why that occurs. We know that diabetes is a pro-fibrotic state, so that fibrosis, that collagen deposition within the muscle of the heart could be a major risk factor and a sign of end organ damage, and it's something that we feel may lead us to new discoveries about how to prevent this damage from occurring in South Asians and in patients in general who have insulin resistance. I mentioned some of the stem cell work that's ongoing, taking a skin cell, reprogramming it into a cell that can become anything, and turning that cell then into a cardiomyocyte or a heart cell, and then studying drug screening is something that we're actively involved in right now with protocols with Joe Wu. Keep going. So the personalized medicine is something that's been in the news every year for the last 5 or 6 years, trying to look at a personalized genome for a patient and turn that into a personalized treatment plan. And that is one of the things that we try to envision for the Sati Clinic and for our patients, that we're able to perform this. And just as Moore's law dictates that it becomes a computer chip can become smaller and smaller, we feel like it's becoming a little bit easier and a little bit easier to do genomic analyses on patients in a high throughput way. And we think that we can apply this on a patient-to-patient basis within the next few years. And then, of course, the cardinal commitment, taking all of that data, taking the clinical data, the medications, the lifestyle changes, and integrating that not only into a health score or a risk score, but integrating that into various apps that can actually interface with our recommendations and tell us in a cloud-based way whether our patients are complying and whether they're responding to our treatments. And then reevaluating that health score is the way that we will approach our cardinal commitment with these patients at 1 month, 2 months, and 6 months into our program. So studying why South Asians have such a high risk of heart disease, using some of the testing that I mentioned. I didn't mention carotid intima medial thickness, which is another strong marker for cardiovascular event risk. Looking at advanced lipid, inflammatory, and genetic analyses, these will all be part of our research program. But it's important to communicate to patients that the research program is completely voluntary, that patients may not want to participate, and that's completely fine. They can still have a very thorough and complete clinical evaluation and treatment long-term in the Sati Clinic without having to enroll in some of these studies. But we do feel like these studies will not only help the patients with their own personalized care, but will also help patients' families and will help the community as a whole in terms of reducing risk. So what can you do to protect yourself? I think I've probably scared you already, but I am sort of trying to scare you into understanding the magnitude of the problem. It's very real. It appears to be accelerating. And honestly, it's very sad. We see it ruining the lives of young Bay Area South Asians on almost a daily basis. We've recently had prominent people in our community die from potentially early heart disease events, and some confirmed, some not. But it's a troubling trend, and it's something that we felt is not being addressed as aggressively as it should be. The sad part of it is that we have proven tests and we have proven treatments that can reduce your cardiovascular risk and your risk of catastrophe, and we need to apply those. And if they need to be applied 10 years earlier, so be it. And that's what our philosophy is. So the question is, what can you do to protect yourself? Well, the first thing is you need to understand what your own risk level is. You have to reevaluate your diet, your exercise, and your social habits. Look at the intake of whole grains, reduce the amount of rice, bread, and sweets that you eat, and increase your protein intake instead. 3 times a week of achieving 80% of your max predicted heart rate, a simple formula shown here, for at least 20 minutes is a start, but you can't know if you're doing that unless you get a heart rate monitor. So playing cricket for 4 hours is not probably going to get to that level of exertion. Get a workout coach if you need to, and set clear goals for weight loss and endurance improvement. And then, of course, you need to have objective tests for your risk factors. What is your cholesterol level? What is your insulin resistance status? And what are your advanced inflammatory markers? And then lastly, get your family checked too. And as I mentioned, I had a patient who brought his 12-year-old son in and who had already been checked for Lp(a) levels. I don't know that I have an answer as to how early to start checking, but depending on the patient and their family history, you can imagine that it may be needed at a much earlier age than we traditionally check. So if your primary physician or your other specialist physicians are not willing or not comfortable being this proactive, we do encourage you to please visit us. We'd be happy to evaluate you and see if you are a candidate for some of these more aggressive screenings. A cardiology consultation is what you would receive from Sati Clinic on your risk and need for further testing. Standard as well as advanced lab testing for risk stratification, insulin resistance testing, dietary consultation, and a genetic risk evaluation as indicated. If you think you are at risk and want to reduce it, you can consider visiting us, but there are many patients who are international, there are many patients who are out of state, there are many patients who have cardiologists already. That's okay. We don't intend to be your cardiologist. We don't have to be your cardiologist. We're happy to be consultants and to give advice on what we think and recommendations. And if there is a need for you to have further testing, if your doctors are willing to do that, we're happy to work with them. And if there's any need that you really want to come to Stanford to be seen, we're happy to see you here as well. But we don't think that this is something that we're doing that's purely magical at Stanford. It's something that can be translated as well as cooperative with other providers, not only abroad, but here in the Bay Area. And so that's something that we're very much open to. And we have many partners already here in the Bay Area with the clinic at PAMF and the clinic at El Camino. We think that we can work together and really make a difference in this community, which is growing in its number of South Asian patients and in this problem that has really affected so many families. Our clinic is actually primarily located in Portola Valley, and I mention that only because the parking is free and the parking is easy. But it's a very nice, smaller, quiet clinic setting. We can actually give you a much more personal experience, we think, there, and a much more stress-free experience in terms of the parking. We also do see patients, however, in the main hospital clinic in the Boswell building at Stanford Hospital. We're adding a Wednesday clinic soon, but right now we're seeing patients Mondays, Thursdays, and Fridays. And these are our contact information. We have a wonderful practice care coordinator, Crystal, who can help with any of these scheduling issues. I'd like to thank you, and I'm happy to take any questions you guys have. Hi.
You have a colleague clinic or institute here at Stanford that originally was called the Stanford Center for Research in Heart Disease Prevention. Jack Farquhar founded it. And when my church sponsored a talk on new developments in heart disease, and a Wagner's last name, Randall, something from that clinic, Stafford. Randall Stafford came and spoke on new information about preventing heart disease. He taught me one of the most valuable things that I have ever heard of, and it has been very useful to me. And you didn't mention it. Somebody, I think at Harvard, did a study that showed that you could very closely approximate the level of small particle LDL, which is the kind that is most dangerous, by looking at the ratio of the HDL and the triglycerides. And clearly you're sensitized to both of those measures. But the ratio is very interesting. If you have somebody, as I have been lucky enough to achieve, where the HDL is 100 and the LDL is 59, then that's dramatically better than the reverse numbers. And have you guys worked with that ratio at all?
Well, the answer, so the question is looking at the ratio of HDL and triglycerides as well as HDL and LDL in our patients. And absolutely, so you're absolutely right that the ratio of HDL to triglycerides is a very good marker of even insulin resistance in some patients. It's been correlated with that. And that's work also that's been shown by Jerry Reeven's group as well. I think it's something that we are definitely collecting, and I didn't go through all of the manipulations of our laboratory data that we'll be doing in terms of finding some of those risks, but absolutely it is a factor grounded in pretty strong clinical work that we can use as a marker to corroborate some of our direct measurements of insulin resistance.
It's an inexpensive thing you can take right off the lipid panel without having to do the much more sophisticated tests to look at it directly.
Yeah, I mean, I think that's true. I also think an oral glucose tolerance test is fairly simple as well. It's just a little time consuming. So, but yeah, I think both are very valuable, and we actually will be looking at both in all of our patients.
Yeah, I
So.
I had three questions. The second one is, there's a couple of authors. One wrote a book called Wheat Belly, and the other one wrote a book called Grain Brain. And there is, in fact, some evidence that humans are not well adapted to eating grains. And that if you eat refined grain, hybrid wheat in particular, that it tends to cause insulin resistance and high blood sugar and so on and so forth. And in fact, the 150 triglyceride level in populations that don't eat excessive grains is atypical. It's actually very high. In Americans, it tends to be normal because it's average, but it's actually terrible. Do you have any thoughts on that?
So the question is refined grains being worse than whole grains, and how it may raise the risk of being insulin resistant.
And grains being worse than vegetables.
And grains being worse than vegetables. I think that we agree. I think that that is definitely a component of the counseling that we give to patients in terms of the types of grains that they have and the mix between particularly green leafy vegetables and sort of the more processed grains that they may find in some of these other foods. So yeah, we absolutely do. Can't say I've read those books that you mentioned. However, the literature does support certainly that there's an impact on the type of grain that you have and your risk of insulin resistance. So.
Yeah. And the third thing is, I've been able to make some very dramatic changes in my heart attack risk without using drugs. Have you any interest? You mentioned putting people on statins, which have side effects, as a consideration. Have you an interest in finding out more about how to create those changes without using drugs?
Yeah, so one component of the question is, can there be non-medical or non-medication-based treatments for some of the cholesterol abnormalities that we see? And finding out more information about that, yeah. So we have, as I mentioned, our dietitian, Prajakta Renate, is fantastic at working with patients to do exactly that without the requirement of a medication, perhaps, to see what their progress is without instituting, for instance, a statin drug or something similar to reduce it pharmacologically. The truth is that while that definitely makes a positive impact for a lot of patients, it may not make it to the degree that we feel it's necessary. And that's on a case-by-case basis. So we don't look at every patient the same, and certainly we may need, yeah, exactly. So there may be patients that are more compliant, there may be patients that are more amenable to those types of approaches. So, yeah.
Yeah, it would be very beneficial to the South Asian community to know that, yes, there are several books on the subject. One of them, of course, by Jerry Levin, Syndrome X, which has been around for a while. And then there's a physician at Banff, Dr. Rajesh Sinha, who's written an amazing book called The South Asian Health Solution. And that book really focuses more on the non-pharmacologic interventions. It really is based on mostly lifestyle intervention. So for people who are interested in not using medications, it's a fabulous read.
Yeah, so the question and comment was, and thank you, is that Dr. Sinha at PAMF has written a very good book about non-pharmacologic means to address some of these metabolic abnormalities. And so that's an excellent choice to kind of get started with that, and as well as Jerry Reven's book, which is one of the seminal contributions.
One question. Would you mind telling us what diet, exercise, and well-being apps you folks recommend in the consultation?
Yeah, so actually, it's a great question. The question is, what diet and lifestyle apps are we recommending? At this point, we are sampling several in our patient population and would not want to recommend one yet, but we've already tried about 3 or 4 that we are interested in using, and they're not just apps, they're technologies that are linked to their own apps within a patient's personal computing device, whatever it might be. So we will have more information about that, hopefully, I think within a year's time, in terms of specific apps that we think are the best ones. But until we can test them in our populations, we found some that are onerous in terms of entering nutritional information. That's usually the biggest problem, is entering your nutritional intake or dietary intake information and how it's processed. And then how the app itself uses that information can be highly variable. And so once we have a better lead on exactly which ones we think are most effective, we'll share that. So, yeah.
I have a somewhat of a different question. Based on your talk today, the relationship between insulin resistance and cardiovascular risk for South Asians, with the recent announcement from the FDA, the cardiovascular risk versus the pre-diabetic risk, particularly things like simvastatin working on the pathways associated with insulin resistance. It looks like that warning may be much more important for South Asians compared to the rest of the overall population.
Yeah, it's an excellent question. The question is this recent link between the use of statins and the risk of insulin resistance being a real interaction, a real correlation. And how do we approach that in our patient population, which may be requiring some sort of treatment early in life, and who are at particularly high risk of insulin resistance already, perhaps? I think that we struggle with that in our preventive group quite a bit, but in the end, we have to engage in that cardinal commitment that I mentioned with patients, that they're going to come and see us regularly, that we're going to follow them long term. If they have an elevated cholesterol that is known to be a risk for coronary disease that we can treat effectively with a statin, and yet they're not insulin resistant at that time, our job as their cardiologist is to treat them for their high cholesterol and monitor them and institute the lifestyle and diet changes that are needed to hopefully prevent the onset of insulin resistance. But in our clinic, we're screening for that. And so we will have a watchful eye on it. But the benefit from the statin therapy outweighs the risk of developing that insulin resistance, especially if we're monitoring for it. And we can actually monitor and modulate our own statin therapy or cholesterol therapy based on whether they were to develop a problem or not. But the benefit is so strong in most of these cases to preventing cardiovascular events for many of our patients that it outweighs that risk.
You talked about in the biomarker, the inflammatory markers.
Yes.
Have you thought about maybe in the case of population of South Asians, a vascular damage marker may be a much more appropriate marker to collect, and something like a RAGE or CML may be a much more indicative of the vascular damage.
So the question is looking at a marker for vascular damage in addition to some of instead of microvascular damage, instead of the other inflammatory markers that we look at. I think it's a great idea. We're not actively doing that just yet, but it's something that down the road we may have the bandwidth to look at. We have a lot of people. Mike McConnell is one of my colleagues who is interested in vascular inflammation and vascular injury, who may really want to know, and that's why we're collecting blood on all of our patients to store, because we may want to do some of these analyses down the road. Thank you. Yes?
How are you creating vascular inflammation at this point?
How are we creating? Treating vascular inflammation. Yeah. So one of the tremendous effects of something like a statin, for instance, is not felt to be just lowering the level of cholesterol in your bloodstream, but is in fact an anti-inflammatory effect. And that is something that we feel is almost like a cooler on the system. However, it's not a dedicated anti-inflammatory agent. We don't generally use anything like that in cardiology for that purpose, but it's a very good question in terms of what brings about the inflammation and how to address it right now our best way to treat inflammation or vascular inflammation is with the statin class of drugs. Thank you.
Are there increased risk factors for South Asians with congenital heart murmur and or sleep apnea problem? And if so, what are they and what symptoms they should be looking for?
The question is, does a congenital heart condition or a genital heart murmur or sleep apnea also demonstrate increased risk in South Asians particularly? I don't know of any sleep apnea data that suggests that it's more prevalent in South Asians, but sleep apnea is underdiagnosed pretty dramatically, just worldwide, and it is strongly linked with not only cardiovascular events like heart attacks, but also stroke and a host of other lung disorders such as pulmonary hypertension and depression and things like that. So it's a major problem. However, I don't know of anything in South Asians that would suggest a specific risk there. In terms of the congenital heart murmur, it depends on the murmur. If you have an innocent murmur, a flow murmur, that's really not something that has been linked with any adverse outcomes, and certainly not in the South Asian population particularly. If you have a congenital heart defect that is shunting blood away from the right places, that has its own list of complications long term, but again, nothing I'm aware of in the South Asian population. So, right. Oh, one more question there.
High Lp(a) is a really important risk factor, right? And I've heard it's more than LDL.
Yes.
Is there anything that actually reduces it?
Not yet. So, first of all, there's no, so Lp(a), the question is, it's a potentially a greater risk factor than LDL for coronary disease events, and that's true. We don't know if a drug that would directly lower Lp(a) will reduce cardiovascular events. However, we may find out soon. There's a new class of drugs that's being studied called the PCSK9 inhibitors. They may have an impact on Lp(a) levels, and they're currently in phase 3 clinical trials and being studied to see if, in fact, they're making an impact on events in these patients. So we may know soon. Okay. Thank you very much.
Thank you.